But in the meantime, I'm going to welcome you all to the Central Square in the name of our brilliant, dedicated, break a sweat board of directors. 23 happens to be women strong. Men, gentlemen are welcome. This is your community as well. But we thank them all for their brilliance and for working so hard. It's such an incredible, dedicated group and think tank of folks coming together. We also have quite a few committees, and there are some brilliant folks from the community who are not on their board, but also participate in. And so those of you who are here, we thank you so much for all you do as well. We have serious fun, even though we work on serious causes. And some of you know us for our Power of the Purse each spring, that we come together to do a program and a fundraiser. But in October 20th, we get together with mostly legal community and others to have some serious fun for a serious cause. You like that? The judges do come gratis. And so we say, judges, yes, but judgment, no. Come and have a cocktail with us at the beautiful indoor-outdoor venue, downtown History, Miami, and learn a little bit about what we're doing with our 4 pillars from the Women's Fund. We thank all of our sponsors and everybody who supports us. No question, we could not keep the doors open without you. So how does this impact collaborative work? It works with other puzzle pieces of what we do at the Women's Fund. We have 4 programs at the Women's Fund. Many of you know us for our official Stop Sex Trafficking campaign of the Miami Super Bowl host committee, or for this current public awareness campaign. This campaign started with an impact collaborative much like this, when we were realizing from partners at Catalyst and Opalaka Development Corporation that their clientele was suffering from extreme heat and it was affecting people's health. So we brought experts much like yourselves together, and that a couple of years ago, now supported by governments, public and private. We're doing an incredibly important collaborative get out the message that we ask each and every one of you here today to do, to let people know that we have to take care of pregnant people, especially in their first trimester and their infants, because extreme heat is not healthy. So we need to make that common knowledge, and thank you all for doing so. That brought us to join the Healthy Babies Coalition, Healthier Miami-Dade, that we'll talk about a little bit later. Our other pillars also include research and data. We have a gender equity dashboard that Dr. Maria Ilcheva, who's our board vice chair, who's in the audience with us today, has helped to spearhead, along with Viviana Alvaro Pacheco, who may be driving this Impact Collaborative soon. We do invite you to come to the Women's Fund Miami.org and look at the data that we have to share with you across our 4 pillars. So, data, research, public awareness, and our very famous grant program. Many of you might know this, but the Lotus House, Urgent Inc., Casa Valentina, Leap for Ladies, FOM, and many other organizations got their very first grants from your Women's Fund. So together, those are our 4 programs, and we base ourselves on 4 pillars: leadership, economic mobility, essential freedom from violence, and today's pillar and focus, health and well-being. We could not be any more thrilled to have this group of leaders together today to address what look like some pretty tragic statistics, but these are statistics that this group in the audience today and on screen know that we can do so much about. To focus us and to set us up for today, we are honored to have Florida Department of Health's Karen Weller here to talk about this issue and get us started. And Karen will ask you to join us later for the Q&A as well. So if anybody has questions, please do know that Karen will be joining the Q&A later as well. Karen, take it away.
Okay, Well, thank you so much for that warm introduction, and thank you to the Women's Fund for this special invitation. Um, and I am going to be talking a little bit from the Florida Department of Health's perspective this morning. And I'll be talking about some of the health outcomes in maternal and infant health, some of the causes, and describe the health landscape in Miami-Dade County, the challenges we face, and what action we are taking to improve maternal and infant health. Please, if you could change the slide. Okay, so you can change it again. Thank you. Okay, so first up, I wanted to give a quick definition of what maternal mortality is. Maternal mortality is defined as a death within 42 days of the end of the pregnancy from causes related to pregnancy or its management. Here, and on this slide, you'll see that the two shades of blue represent Miami-Dade County, and the shades of orange represent the state of Florida overall. The lighter shades of each color represents the Black maternal death rate, and the darker shade represents the white maternal death rate. So as you can see, you'll see that there is a bit of a disparity. You can see that for both geographies that Black maternal death rates are consistently higher than white maternal death rates. The disparity between these two rates is highest at the overall state level. Next slide, please. This slide shows the causes of maternal death, where each box is sized proportionally to the number of deaths. So I'm not going to go through each one of the different causes. You can see them there. But basically, in order to get a fuller picture of the leading causes of death, this slide was created using the data from the entire state of Florida for a 5-year period. The top 5 causes are listed with the definitions on the side, but please pay attention to the number 1 category of causes for maternal death, which involves pre-existing conditions that can get worsened once a woman becomes pregnant. And this includes such diseases as hypertension and diabetes. It is important to note that chronic diseases in the community is a preventative measure that can be dealt with, but it does cause maternal death. Okay. Next slide, please. Infant mortality is defined as the death of a baby within the first year of life, and the rate is how many deaths per 1,000 live births. This chart shows both breakdowns by ethnicities and race. You can see that when looking at race, Black infants have 3 times the mortality rate than white infants, and is significantly higher than the overall rate. When looking at ethnicity, non-Hispanics have higher mortality rates than Hispanic. Please note that the race and ethnicities are separate and different, but they are displayed here on the same graph so that you're able to see the scale and be able to see things clearly. Now, just want to note too that our infant mortality rate for Miami-Dade is 5.8, and when you look at that, that's a low rate, and it's lower than what the state is. However, we still have a lot of disparities, and of course, we want to even get that as lower as possible. Okay, next slide. Okay, shown here is a chart depicting the 10 top causes of infant death, where each box is sized proportionally to the number of deaths. This was created using data over a 5-year period just for Miami-Dade County. The top 5 causes are listed with the definitions on the sides, just as we did for the maternal child area on the maternal slide. I'd like to highlight the number 1 cause of death among infants is the extreme low birth weight and extreme immaturity. Low birth weight and preterm births are not only a risk for infant death, but also carry serious health implications, even if the baby survives. We will show the rates of low birth weight and preterm birth next. I'd also like to highlight the 5th cause of infant death, which is suffocation and strangulation in bed. This is definitely a preventable cause of death, and we are working towards reducing that in our community. And we'll touch on this a little bit later in the presentation. Next slide. As previously mentioned, preterm births and low birth weight carry serious health implications for the baby, and in most severe cases, death. The orange line in both graphs show the county's overall rate. Preterm birth, which is a birth at less than 37 weeks gestation, disproportionately affect the Haitian and Black communities. Babies go through important development, even in the final weeks of pregnancy. Infants born in the preterm area have a higher risk of infections, developmental delays, and breathing problems. According to the CDC, the following factors are associated with preterm birth: age, especially with teens or women over 35, low income, tobacco use, substance use, stress, prior preterm birth, infection, and carrying more than one child. Though the causes of preterm birth can be complex and not always understood, there are certain things that we can do, like quitting smoking and not using any adverse substance, getting early prenatal care, and waiting 18 months between pregnancies are actions that can help reduce the preterm birth. Low birth weight, which is any weight less than 2,500 grams, disproportionately affects the non-Hispanic, the Haitian, the Puerto Rican, and Black communities. Low birth weight and very low birth weight is primarily caused by preterm birth, and so has the same risk factors and consequences. And the graph there shows everything that I spoke about. Next slide, please. Teen pregnancy carries serious social, economic, and health implications for both the mother and the infant. And as you can see from this slide, it has been going down since 2011. However, there's still a concern. Babies born to teen mothers are more likely to be premature and are at higher risk for low school achievement and to become a teen parent themselves. Teen pregnancy can negatively impact the teen mother's health and their educational and job opportunities later in life. The chart in the center shows the number of births to mothers ages 15 to 19 years old in blue. The orange is a subset of these births where the teen mom has already given birth before, in other words, repeat births. Both categories of teen births have been decreasing over the past decade, as I mentioned earlier. We have a community health improvement plan that our health department is responsible for putting together on every 5 years. And one of the goals that we have for the community health improvement plan is to see a decrease in repeat teen births. And so if we look at the goal for our, and I'm going to call it CHIP just to make it easier as we go forward, we have met our goal. But we still want to continue working on that. We also want to be able to meet it across all of the ethnicities, and in some cases we have not really met that as well. So we'll keep that in mind. Okay, next slide. The Kulachuk Index, I might not be pronouncing it correctly, but anyway, is a way of measuring if a pregnant person received early and adequate care, and is on a scale of inadequate, intermediate, adequate, and adequate plus. Adequate and adequate plus are the green shades, and intermediate and inadequate are in the purple shades. The blue line is the overall county percentage, and the black line is the Healthy People 2030 goal, which is our national blueprint for health. So the way to look at this is that by 2030, we want the graph to be shades of green up to and past the black line. And as you can see, we are not there yet. You can see that currently by ethnicity, the Haitian and Mexican populations have the lowest percentage of adequate prenatal care. Haitian and other Hispanics have the highest rates of inadequate category. In other words, they're pretty much in the dark purple and blue area. By race, the Black population has a slightly lower percentage of adequate prenatal care. All categories have a ways to go to meet the Healthy People 2030 goal of 80.5% of the population getting adequate prenatal care. Next slide, please. In 2021, when we're looking at the providers that we have in the community, there were 28.1 pediatricians per 100,000 people living in Miami-Dade County. This is better than the overall state average, which has a rate of 21.9 pediatricians per 1,000 population. Miami-Dade County has the highest rate among all counties of Florida and the largest share of pediatricians. For example, of the 4,743 pediatricians that we have in the state, We 805 of them are here in Miami-Dade County. In 2021, there are 8.5 OBGYNs per 1,000 people in Miami-Dade County. This is lower than the overall state of Florida rate, which is at 9. Miami-Dade has the largest share of OBGYN. Of the total, we have 2,000 OBGYNs in the state. We have 244 of them here in Miami-Dade County. We are slightly above the median rate of OBGYNs among the counties in Florida. Next slide, please. When we're talking about accessing care, it's not just about having enough licensed professionals for the population, but it's also about providing care that is linguistically and culturally appropriate. While there isn't currently a measure for linguistically and culturally appropriate, having healthcare professionals who mirror the characteristics of the population is a good place to start. So here you're seeing the graphs for the different areas. So while this data was not available for specific doctors, if you look at pediatricians or OBGYN, you can see that the race and ethnicity distribution among nurses and doctors does not perfectly match the demographics of the overall community in Florida. Asian and whites are overrepresented in this profession, while Hispanic and African Americans are underrepresented. This data comes from the Human Resources Service Administration and the U.S. Census Bureau. And if you want to find out where we're getting the data, just let me know, and I'll be happy to share with everyone. Okay, next slide. So some challenges. We have existing health disparities in the community that directly impact maternal and infant health. The leading cause of maternal death are chronic conditions that are made worse when a woman becomes pregnant. We are working to approach these health equity. We need to look at the social determinants of health. We need to be looking at the problems in the community through a health equity lens. And I do believe that we have so many people that are here today that are working towards this. And so I think collectively together we'll be able to work on that. And I'll share more about what we're doing in a minute. We do have to look at the policy system and environmental changes that need to promote the overall health of mothers and infants and to really address the disparities that are here today. And I do believe, and we are there working to improve the collaborative efforts that we're all going in the same direction will help us very much. But one of the things that we do have as a challenge is that sometimes we do work in silos. So being able to work together is going to be very, very important. And one of the other challenges that we do have is that we do lack data at the zip code level. We have some, but there's so much other data that we need to be able to get to really see where we need to be putting our efforts. Next slide, please. Okay. The Department of Health in Miami-Dade County provides staffing for the Consortium for a Healthier Miami-Dade. And we do have, for this specific initiative, we do have the Healthy Baby Task Force. And I'm so excited because, of course, the Women Fund is part of this collaborative. And we have so many people that are on this call that is part of this collaborative. And we're very, very, very committed for us to work together through this collaborative and through many of the initiatives that are going on within the community. The members of this task force has been conducting a safe sleep campaign to promote safe sleep practices in the community so that we can reduce infant mortality. This campaign has included conducting focus groups and surveys to learn more about how our community views safe sleep recommendations in order to better spread the message and improve knowledge among new parents. The task force has also worked to promote breastfeeding by increasing resources, providing education, and promoting workplace policies that support breastfeeding. The Community Health Improvement Plan has strategic priorities of health equity, and maternal and child health has its own strategic priority within our Community Health Improvement Plan. And both are working to improve the overall health of mothers and infants in Miami-Dade County by increasing awareness of health equity as an important concept and lens to conduct all work through and by working together to provide information on safe sleep, provide family planning education, targeting healthy pregnancy campaigns towards Black and Hispanic communities. And one of the things that I want to share is that our health department was very, very fortunate to receive a CDC grant. The grant that we received deals with the COVID-19 pandemic, dealing with the aftermath of that, and also dealing with health equity. And through that grant, we have been able to put out many grants in the community to be able to fund some of this work. So I'm very happy to share that we do have a grant, a contract with the Metro Mommy Agency that has been working out in the community. We have another grant with Southern Birth Justice Network that is working in this area. And these two agencies are specifically working in the maternal child area. So I am very excited about the work, and in a future presentation or meeting, we can share more about the actual work that's going on, because of course this work is broader. We have CLT Business Solutions that's working on a specific curriculum that talks about health equity and the ways that we can work in the area of dealing with the social determinants of health. So with that, next slide. It's very important that I share with everyone that in order for us to be able to make an impact, we do need to work on the social determinants of health, because if women don't have housing, and it's not just women, families, if we're having problems getting houses, if we're having problems with transportation, this all affects the health of the maternal infant dyad. So that's very important. We, as a health department, we are required to do extensive community assessments. And so next year, our plan it's going to be time for us to redo these assessments. And so rather than we try very hard to get all the hospitals in the community to work together on doing these assessments, all the community-based providers. And as the years have progressed, we've been able to do that. And so as we get ready to move into doing another assessment where we're working on our priorities, we will be asking for everyone's help. Right now, it is a strategic priority in our current plan. When we get ready to do our next one, we need to look and see if that's going to continue to be our strategic priority. So we will be asking for your help. We also have maternal child health as our strategic priority. As we go forward, we're going to be needing your help again to see if that is going to continue to be our priority, and to be able to get specific so that we can put this in our plan. So as we move forward, we can ask all of you to help us to be able to collectively work together. As a health department, we always look at the population health. And so this is something that we will be working together with the community, because we want to be able to bring everyone together. And with that, next slide, please. I am done with my presentation. And so thank you so much for this wonderful opportunity.
Thank you, Karen. This is incredible. And you are absolutely right. We are stronger together, and there are the people here today who can do a lot about sharing this and moving this forward. I know that some of our team is really excited to see how we can help focus and get some of that necessary data as well. And we look very much forward to focusing a lot of the data that you all have to offer on our gender equity dashboard. So this is your Impact Collaborative, folks who are here. We have many members from the community, health leaders and community leaders here today. Please do use the chat, introduce yourselves, say who's here. Do fill in the polls. You'll have a poll later that's going to offer you the opportunity to connect further with some of our speakers today, because the conversation really keeps going and really gets revved up from today. We've got much, much, much work to do together. You'll see later on that you'll actually have an exit survey as well. We take the surveys really seriously, so please do answer that when it's in your inbox as well. So This is almost the last you're going to hear from me because I'm going to turn it over to Viviana Alvaro Pacheco to drive after this section because I don't want to slow anybody down with my slow connectivity. But first, before I turn into just a listener, I'm going to ask each of our panelists to do the absolute impossible task of introducing themselves in 2 minutes or less. And how can we ask them to do that? How do we dare? Because we ask them to introduce themselves within the context of today's topic. So why they're here, and then we'll ask them after that to ask in 3 minutes, tell us in 3 minutes or less what they're seeing, what the reality is, what we need to know as a community. And then that same four will come together and say, please, this is what we need to do in 3 minutes. They'll tell us the situation. What are you seeing on the ground? What do we need to know? What's cutting edge? And after that, Karen Weller will join the Q&A and Viviana will be driving. Thank you so much. And please introduce yourself, Dr. Rokeisha Renee Ashley. Welcome.
Good morning, everyone, and thank you so much for having me this morning. My name is Dr. Rokeisha Renee Ashley. I am first a mother of a 5-year-old beautiful baby girl named Emery Ashley, and I'm also an assistant professor of communication at Florida International University. My research specializes in an experience of that I've had of morbidity when I was hospitalized for a couple of days after I had my daughter, and then also for her being at risk for infant mortality as well. So my research is in Black maternal health, and I focus specifically on health communication strategies on how we can use communication to reduce morbidity and mortality for Black women.
Thank you so much, Dr. Rokeisha. And up next, we have Joanne.
Good morning,
Welcome,
everyone.
Joanne.
Good morning. My name is Joanne Rogerio, and I am the Chief Executive Officer at the Holtz Children's and Women's Hospital. All of my background is in maternal health. I am a maternal health nurse by background, and in all of my work in my leadership roles have really focused on how to make the acute care setting a place where all of the work that's done in the communities does not become undone by what we do in the acute care setting, really helping to set partnerships and bridges to ensure that we can really affect patients' outcomes here in the hospital through making sure that our care is both clinically competent, but more importantly, culturally competent to the patients that we care for. And so as we go through, I hope to be able to tell you a little more of that, but I'm really happy and grateful to be here with you this morning.
Thank you so much. We're so grateful to have you here. Jennifer?
Hi, good morning, everyone, and thank you as well for having me to be here, a part of this conversation. My name is Jennifer Ellisey. I am a research business analyst for the Children's Trust, and a part of my role at the Trust is helping to provide support and content and expertise to our Thrive by 5 early childhood development portfolio, which is very much focused on providing support and investing in strategies that help support children's physical, cognitive, and social emotional well-being. Prior to working at the Children's Trust, I actually worked for the Broward Healthy Start Coalition on a project that was funded by the March of Dimes, and that project was called Healthy Babies Are Worth the Wait. And so the overall premise of that project was really discovering reasons why there were high preterm birth rates within certain areas within Broward County, and ways that we could help to alleviate or improve those high rates. And so I was very much focused on birth equity. Currently, I would say I have as well the joy of being a BUILD initiative, Equity Leaders Action Network Fellow. And so that's basically a leadership program that focuses on allowing and helping individuals to use their influence and their role within the community to promote more equitable early childhood systems. So I'm very much engaged in this conversations, looking at more of like the systematic, individual is important, but also the systematic implications that lead to our maternal and infant mortality rates that we're seeing.
Thank you so much, Jennifer. Fernanda?
Hi, good morning, everyone, and thank you to the Women's Fund for bringing this amazing panel together. I'm just really honored to be a part of it. I'm a director of programs at the Health Foundation of South Florida. We are the largest philanthropic organization in South Florida dedicated to reducing health disparities and achieving health equity. And in my role, I work really closely with our leadership, with our board of directors, and with our community to make sure that our investments align with our mission, which is to not only be an investor, but also be a catalyst for collaborations and policy and systems change to improve the health of our communities, focusing on vulnerable populations. My background is in anthropology and public health, so I've always been really fascinated with the human condition and communities and population health. I've dedicated my entire career into addressing access to care issues. And I really believe that health is an essential human right and social justice issue. And then last but not least, and perhaps most important, I'm also a new mom. I had a pandemic baby who now is a post-pandemic toddler. And so I've recently just had the experience of going through our system and had some ups and downs. So I think I also have that perspective to share. Thank you so much.
Thank you so much, panelists. We're so glad to have you here. Now we're going to move on to the issues portion. So what you should know. What can you tell us about the issues and what should the community know about these? And we'll start with you, Dr. Rogerio.
Great. I'm Camila. Do I have my slide? Oh, okay, great. So first I want to say that Karen was so efficient with making sure that the statistics were highlighted about issues for maternal morbidity and mortality and also infant mortality. And I want to think more closely about Miami-Dade and of course Broward County. And first, I would like to say that sometimes when we have these conversations about maternal mortality, and obviously I'm always coming from the lens of a Black woman, a Black mother, and then also as a researcher, is that sometimes we can situate Black birthing persons into a deficit framework, right? So that these issues are, of course, prevalent for Black birthing persons. However, we have to understand that there are a number of opportunities and organizations and Black women who are mobilizing in communities that are trying to alleviate some of the key issues that we have. So number one, we know that we're dying at more alarming rates than our white counterparts, 3 to 4 times more likely to pass. And then also our children are more likely to die within their 4th year than their white counterparts as well. And particularly within Miami-Dade County, our institutions of health, our mainstream institutions of health, so our Jackson Hospital system, that are allowing our birthing persons to come into their facilities, they are more likely to have cesarean rates higher than the state average. So what that means is that when Black birthing persons are more likely to come in with their own birthing plans or even having those pre-existing conditions that Karen Weller spoke about earlier, they're more at risk of having a cesarean section, which puts them more at risk for a morbidity instance and then also for maternal mortality. And what can prevent these items from happening, right? What can prevent cesarean sections from happening is having advocates right there in your birthing space. And I've been privileged enough to follow a group called Southern Birth Justice Network, which I'm sure a lot of you all are familiar with, for the past 5 to 6 months, to understand how they're communicating with the community about and Black birthing persons about how they can be more of self-advocates for themselves and utilizing doulas and having access to midwifery care, and how this can prevent, of course, cesarean sections. But even if you have to have a C-section, then you can be in a position where you are more apt to have a smooth labor and delivery process. So number one is that there is less access to doula and midwifery care in Miami-Dade and Broward counties. So what does that look like for Black birthing persons to gain access? Number one, there has to be education around this, right? So how do we make sure that Black birthing persons are informed about some of the rights that they have to having more people involved in their labor and delivery process, particularly a doula who works as an emotional and educational advocate for Black birthing persons. And I keep saying Black birthing persons because that's where my focus and my emphasis is. So that's number one. And then also understanding the priorities that they have when they go into these spaces, because 9 times out of 10, when they're going into mainstream health organizations, they feel like a number. They feel like they have no rights. They feel like they cannot advocate for themselves. And doulas and midwives operate in a fashion where they are collaborative in nature, and they specialize in making sure that the care that the Black birthing person wants is what they desire, as long as it's within the scope of their healthcare plan. And then also, when we think about when they go into having their babies, we have to make sure that they are equipped emotionally and educationally. So doulas often provide support before they even go into the labor and delivery room. So as they're going along their prenatal journey, they have someone who's there specifically to make sure that they're informed, they are aware, and that they, if they cannot advocate for themselves or they choose not to, they have someone present for them. So understanding that Black birthing persons are more likely to have cesarean sections, and they are more likely to die from that process, they should be able to have more access to doula and midwifery care to support the needs that they have in labor and delivery process. I'm not sure if I hit 3 minutes.
That was wonderful. Thank you so much, Dr. Rokeisha. So insightful. Up next, we have Joanne.
Good morning. Dr. Rokeisha, that's my hint to turn my timer on. So I just want to go through this very quickly, and also making sure that I am putting out front that I am speaking from an acute care perspective, and some of the opportunities that I see not only here, but also from experience that I bring with me, really align with a lot of what Dr. Rokeisha was saying. And some of the things that we are doing here at Jackson to try to address these are really working on an overall holistic program on how to create community connections between our acute care setting and all of the community resources that there are. This morning in our keynote speaker, when she was speaking, she talked a little bit about utility. And we see that we have the physicians, we have the providers, we have so much of our community programs that are all working to really address our maternal health crisis, I'll call it. But how do we together as a team come together to ensure that everything that we're putting together, that we actually have utility in it, that our patients are able to get there and utilize it and find value? Because when patients find value in what we are giving to them, they are more likely to come and do that. Some of the programs that we are working with, we are partnering with the Southern Black Justice Network, and we are actually inviting them in. And what we realize is, unless we create here within our hospital a place that is both doula friendly, both patient centered, ensuring that we have the mechanisms in place, not only for those patients who maybe have a doula or who have access, but to all of our patients. Why do our patients have to go out and find a resource to create a birth plan? We want to provide that to our patients. And so we are currently working with our teams to create a birth plan template that patients can prioritize and make their own. But we also are going through a process where we're working with a current student and one of our physicians to, when we talk about doulas nationally, what we know, the evidence is clear. We don't need to research this anymore. Doulas promote better healthcare for our moms. What we need to do is ensure that we have the right amount of doulas. And with all the call currently happening with doulas, we need to support educational programs to help doulas become doulas from our community and do it in a way that supports them by opening the door for our doulas in the community who want to become doulas, so that we can provide their clinical hours here. And we're currently working on a program where they can get their training here. We will welcome them in. And then Jackson is really pushing to be the first health system in the Miami-Dade County who actually employs doulas, makes them a part of our care team. They don't need to come from the outside. If we have a patient who doesn't have access, we want to provide them with that access. In the last few years, Jackson has seen a 28% reduction in our C-section rate. And in April, we saw a C-section rate that was lower than the national benchmark. We want to continue that work by ensuring that we are creating bridges with our community partners, because we recognize that we could do everything we can within the walls of this acute care hospital. But if we are not connecting with our community providers, everything that we do will be in vain. And I think I'm over my 3 minutes.
No, that was wonderful. Thank you so much, Joanne. So important to really have the healthcare system on the side of the birthing people and really for the community. Jennifer.
All right, so I honestly feel like I'll just continue to build on a lot of the great things that were already said, as well as re-emphasizing something that was shared in Miss Karen, Weller's presentation earlier, just the importance about access to quality care. And when we discuss what quality care consists of, that means more than just having a knowledgeable and well-skilled, right, healthcare provider, or even being able to have access to a very well or highly rated health institution, but rethinking, right, what really makes quality. And that's also ensuring that healthcare providers and health institutions have that level of cultural sensitivity, as well as the linguistic capacity to be able to relate to and connect with the women and the families that they are serving. And so as well, you know, and thinking about quality, so there's that component of the cultural, the component of the linguistic, which we know Miami-Dade County is a very diverse community, right? And also in looking at quality, there's that element of empowerment. So I also wanted to put that level into that as well, in that empowering women to be able to advocate for themselves, empowering women to understand their health, to understand their reproductive health is very critical. So all of those components, to me, along with being able to identify, for healthcare providers to be able to identify the etiology of diseases, and to be able to help develop interventions for women to be able to improve their health outcomes. There's also that need of understanding the community and meeting the community where they're at. I would also say that it's important, there's a greater need to hear from the community what the issues are. So I think we have great access to a lot of data that might tell us what rates we're seeing within the community, but it's very helpful to actually speak with the community to understand why we're seeing the rates the way that they are. And some of the work that I know prior, when I was working with Broward Healthy Start Coalition, we've done data walks, for instance, in areas where we saw there were high rates of preterm births. And we actually asked the women there in those communities, why do you think that these rates are at the levels that they are? And it was very interesting to hear from the women, you know, the varying perspectives, whether it was stress or the lack of support that was contributing to their preterm births, which, as was shared earlier, is a risk factor for infant mortality. And then the last point that I would say is another important issue to address is also just having more coordinated systems of care. So that was also shared by Karen earlier. So we know that within Miami, I think we have a lot of well-meaning institutions, well-meaning organizations that care very deeply about the issue and the topic that we're discussing today. But there's no way that we can make progress in this work if we are all working in silos. And I think that one of the ways that when we talk about coordinated systems of care, an integral component of that is having integrated data systems, you know, because it's one thing if we want to be able to get a better picture of the maternal health landscape, to get a more comprehensive look of that, we need to have more integrated data systems that are not just focused on what the data is saying in terms of health, right? Health outcomes, but looking at what's going on with housing and what's going on with our education, what is going on with food security. So there's many things that we have to look at holistically, to get a better picture of what maternal health looks like. And the best way that we can do that is through individuals like us and many of us who are on this call today, working towards having more integrated data systems.
Thank you so much, Jennifer. So true. Really one of the reasons why we're so excited and happy to have this conversation and to have all of you here. Next up, Fernanda.
So it's always a challenge to be the last one to go because a lot of the panelists have already touched upon a lot of the things that I also agree with. But I do want to highlight and amplify. Karen mentioned the social determinants of health, right? We know that the non-medical drivers like poverty, housing, transportation, these impact us so much more than, you know, just healthcare alone. So unfortunately, although there's this huge unmet need with social needs, health systems and the social service sector still operate in silos. So we definitely need large scale social change. It requires a lot of coordination among the two sectors, and we're just not there yet. We have to help push health systems to be able to look at health broader. Even last night at the town hall, Mayor Cava, housing, you know, everybody knows it's a huge crisis here in Miami-Dade. So if you don't have access to housing, you don't have access to transportation, you know, you're much more likely to have worse health outcomes. And, you know, with pre-existing conditions, we saw that with COVID, right? Why did COVID impact the Black community much more than others? Because of existing pre-existing conditions. But why is that, right? We have to look beyond the personal factors and lifestyles and look at what's happening in the community. And then finally, I will just say that beyond all of this is really there's an overall general lack of investments and policies supporting women and children. I feel like parental leave is central to the equity conversation, right? Right now, you know, maternal leave is, you know, not everybody has equal access to it. And it's really leaves the woman or birthing people to fend for themselves. Right. And it's complicated finding childcare, postpartum depression. So I think we need to think also more broadly in what policy changes are needed to support women before, during, and after pregnancy, not just women birthing people before, during, and after pregnancy. Thank you.
So important to really look at all of these issues within, as Jennifer said, a holistic view. And now that we have our issues, I'd like to invite everybody to please do our second poll and answer just the quick questions that we have. And now we'll move on to the solutions portion. It's now that we know everything that we need to know. So what can we do about it? What calls to action do you have also that you can bring forward and share with the community? Resources, anything you'd like us or the community at large to know, please feel free to share. And we'll start again with Dr. Rogerio.
So I advocate for doula and midwifery care for Black birthing persons. And I think that there is significant change when they are present. However, when I think about my experience as a 26-year-old Black cisgendered woman having her baby, I was studying for my doctoral degree. I had 2 doulas, a midwife, and an OBGYN, and still almost lost my life, and my daughter almost lost hers. So when I think about how impactful they were, I definitely credit my doulas to saving my life. They were my advocates. And when I was going into shock, they were the ones who were speaking up on my behalf. They were the ones who identified that my daughter was severely dehydrated. And I am grateful for that. However, I know that there is much more that can be done within the system. So when we think about having access to quality care, we'll have our doulas and we will have our midwives who will have a different kind of connectivity to clients who are more culturally competent, who are more sensitive to racial disparities. But there has to be an overall shift within the curriculum development of how we're training our physicians and practitioners who work in mainstream medical facilities. So when we think about how the doulas are supporting our Black birthing persons going into the labor and delivery process, well, who are they going in to see? Who are the OBGYNs who are on call, who have no record or knowledge of the history of being with this patient if their doctor is not present? What does their competency look like in terms of understanding racial disparities, and then also understanding how to communicate, not only like with the linguistic challenges, but how to communicate about some of the health practices or some of the health history of the patients, and not labeling them as like non-compliant or just, doing a kind of overview of whatever their medical history is, and not understanding the limitations or other factors that may impact them in the labor and delivery process. So I think it's very important for there to be some type of curriculum revision and development for mainstream medical programs. I know that there's a lot of major universities that are engaging in the conversations now. So like Boston University, University of Miami is doing something as well, but there hasn't been curriculum development that directly talks about some of the historical impacts of gynecological care in America related to Black persons. So instead of thinking of J. Marion Sims as the father of gynecology, but let's think about who are the mothers of gynecology for Black birthing persons, or who are the people who were pioneers in identifying the issues of how gynecology was even developed in the American system, right, on the bodies of Black women. So thinking about some of the historical antecedents that preceded this care system needs to be embedded in the curriculum that our medical students are engaging in and learning now. And that has to be amplified. It has to be very present. It can't be a cute training, a nice workshop. Those are always fun, right? But we have to definitely make sure that there is more of a thread, just like they do rotations. This needs to be a part of that. And then also I am thankfully, thank you, Dr. Okezie-Etovo is in the attendees. I'm also the co-lead of the Black Mothers Care Plan developed by Dr. Okezie-Etovo with a host of other amazing researchers and scholars who are committed to seeing doula care extended for Black birthing persons in Miami-Dade and Broward County. So looking at how can we develop programming that's community-led, reproductive justice-led, and immersive for programming in mainstream medical facilities. Right now, I know that SBJN is definitely actively working with Jackson Health System to create this program, but how do we make sure that it's led by the people it's affecting, right? Using community participatory action kind of methods to make sure that we are stimulating and leading with the Black people who are being primarily affected, and those who affected, and also those who are mobilizing to develop programming that's going to be actually responsive to Black birthing persons. And then also extending doula care for Black birthing persons. So thinking about not just up to 6 weeks, because postpartum it lasts up to 3 or sometimes 5 years. So when we think about making sure that our children are taken care of, that the birthing person is taken care of, it should not stop at 6 weeks. So extensive care to make sure that our Black birthing persons are taken care of. So my primary thought in terms of call to actions is not for Black people, not for Black women right now. It's about the medical system and how we're producing our physicians. So making sure that these OBGYNs and physician assistants and anybody who is operating in a mainstream medical health facility, that they have a thread of racial disparities in their curriculum or reproductive justice that is embedded in their curriculum, to make sure that they understand when they're going into care for Black birthing persons, that they understand the ramifications of their actions and how to prevent things that have happened in the past. And I think that's a sure way to reducing morbidity and mortality.
Thank you so much, Dr. Rakisha. So important. So glad that Dr. Otovo is here in the audience, really leading that program also to have a better understanding for physicians and nurses and anybody in the healthcare system to support all birthing people. Joanne.
Hello. I wanted to start by when we think about solutions, there's, one of the things I tell my team often is there are models that have worked, and how can we look at those models and see how they work in our community? But this morning at the beginning, when Karen was presenting her slides, and you look at all of these disparities of healthcare that exist, there is one common theme that goes across all of them that has an impact on the later morbidity, mortality, neonatal morbidity and mortality, and that is early prenatal care. And each one of them, if you look at the evidence, we look at the data, having moms access prenatal care within that first trimester is really a key to ensuring that the health of throughout that pregnancy and then beyond, the patient gets better care. So I think that we need to focus there, because when we do, we really are able to focus on making sure that we get mom the appropriate interventions that he or she needs in the moment that we get them. But how do we do that, right? And that's the question that everybody always asks. And, one of the things that we have really been focusing on again is, if we could imagine a hospital without walls, that's really what my vision for our institution in this time is. That how do we think about community health workers and really placing them with the moms who need them the most, specifically after they deliver, when they go home. We understand that, moms are faced with so many challenges once they go home, and having those community health workers, the doulas, strengthening our partnerships with the family nurse partnership. There are community establishments that are there, and how do we strengthen them? I think Fernanda, when she was talking about our opportunities, she had mentioned that we're still so far from where we need to be when it comes to really collaborating with the acute care, with the community. And how do we focus our efforts there to bring all of the work that we're doing together and then move forward together, whether it be about safe sleep, whether it be about social determinants of health? How can we all find a common thing that we can focus on and then move our community forward in those one or two things? It for me is the most important thing. When I think about solutions, I know it's very broad, but how do we come together and dissect that so that we're moving together rather than moving in different directions? So that would be one of the solutions, I would say, for addressing some of our opportunities.
Thank you, Joanne. Absolutely. Stronger together and working collaboratively is definitely key. Up next, Jennifer.
Yes, and so in this conversation about, again, looking at what are potential solutions, when we look at what some of the leading causes, right, of maternal mortality are, like the risk factors, and we see that a lot of those leading factors could be due to like cardiovascular problems or hypertensive disorders. Things, as Karen had shared earlier, are very much preventable or could be exacerbated during pregnancy. I think another area that I would say we can focus efforts or interventions is really in that preconception health space. So before a woman even gets pregnant, or a birthing individual, gets pregnant, is for us to really assess whether or not individuals are at the most optimal health to have a baby. And so for me, when we say preconception health, that's not just, at the moment, right, of conception is when we begin to have these conversations about maternal mortality, or how do we decrease maternal morbidities, but it's thinking about as early as in the early childhood space, right? Thinking about what access do children have to healthy meals? How are we ensuring that all children have access to healthcare, right? Really thinking about the communities that children, are living in, because ultimately these children are the ones who are growing and developing into the adults that we see today, and that are experiencing, the very much issues that we're talking about in maternal mortality. mortality and infant mortality. Another thing that I wanted to share as well, as Joanne was speaking just about, like, I love how she said, you know, kind of having a center with no walls and thinking about like, what are the solutions that permit us to work together? One of the things that I've really been looking at in terms of how do we collectively bring individuals within a community together in a way that is effective, and especially when we start talking about issues related to, let's say, equity or disparities. These terms in and of themselves can be very polarizing. Believe it, you know, in the society that we live in today, unfortunately, you know, when we have these conversations about what the data is showing us in terms of inequities and disparities, we can get lost in some of the unnecessary, I guess, just either jargon or different perceptions about who needs assistance and who doesn't, that really just causes us to lose sight of the real issue at hand. And one of the frameworks that I've really been looking at that I think that could be very effective here within Miami-Dade County is a framework called the Targeted Universalism approach, which I'm not sure if some of you have heard of. It created by John Powell over at the Othering and Belonging Institute over at UC Berkeley. And that framework really centers upon communities, first of all, coming together and saying, okay, what is our shared common goal? Identifying a common shared goal and being willing to say, okay, in order for us to achieve this shared common goal, what are we being successful as? What are we being successful in, in a community to achieve that common goal? But what are also the areas of weakness and areas that need to be improved in order to achieve that goal? And so what that requires the community being comfortable enough to say, hey, let's dissect the data and let's see where those disparities exist. And we do want to target interventions in specific areas, maybe for different groups, not for the sake of just highlighting and saying that, you know, only that group is of importance, but in saying, in order for us to accomplish the overall goal we want to achieve, we have to make sure all groups and all different levels are up to par. And so an example of that could be as if we say here in Miami-Dade County, and many of us here on this call and partners, if we're saying, hey, our overall goal is that we want, you know, women, children, families to be able to experience the best life and the healthiest life possible, that means us taking a deeper dive into what we're doing today, right? And saying, okay, where are we being successful? But again, where can we maybe target more interventions in order to accomplish that overall universal goal? So I just wanted to put that particular framework out there, because I know that, you know, a lot of us are very well-meaning and we want to work together, but I understand that sometimes, you know, the work that needs to be done in order to bring us together, you know, we have to find ways that causes us to be less polarized and more unified. So I think that particular framework can be very helpful.
Absolutely. Thank you so much, Jennifer. Fernanda?
Yeah, Jennifer, I love that. And before I say what I think, I just want to also thank Dr. Ashley for sharing her really powerful story. I did mention the role of non-medical drivers on our health, but you know, differences in socioeconomic factors does not explain fully racial inequities that we see. These are a result of like deeply embedded structures and systems and policies in place that have been for generations that are really driving those inequities as well. When I think about improving Black maternal health, I think of several different things, right? We have to increase access to coverage. It's only been recently, as of last year, that even Medicaid coverage for postpartum went from 60 days to 12 months. So that is a huge win. I think there's a lot of things that we're doing right by collaborating and coming together. I definitely agree in improving the workforce, right? And expanding the workforce to include doulas, midwives, and community health workers. But if there isn't funding mechanisms to sustain these positions, then we're not going to get anywhere. So to me, I think where I would focus and where Health Foundation is really focusing our efforts is in healthcare and changing healthcare delivery and financing. So maybe because we're a funder, I'm always thinking about funding and financing. But if we don't have the systems in place to be able to bring these models that work, that we know are effective and sustain them over time, then we're just going to have programs that come and go. So I really think that a role for philanthropy is we can do some pilot testing of models and see what works, make sure the community is engaged, bring community providers, work with our health systems, everybody come together, test something out and show the return on the investment so that we could either get, government to come in, public dollars to come in, or other financing mechanisms to make sure that these initiatives are sustained over time. As of now, Florida is one of the few states that does have reimbursement rates for doulas, but because of the way ACA did it, that it's up to the plans, not every plan is either reimbursing at the same rate or even allowing this benefit. So there's discrepancies there. So again, I think we have to think broader of, what works, and then figure out at the same time, how do we get them to last over time and be sustained?
Such a huge part of the work, right? The funding, really being able to add in the dollars to support all of this great work. Thank you so much, Fernanda. And thank you to all of the panelists. We're really so grateful for all of your insight and for all of your solutions to this super important problem that we're very interested in learning more about and knowing how we can solve it collaboratively. We'll move on to the Q&A portion of our event today. Please use the Q&A tool to post your questions or use the chat, whichever one you prefer. We have our third poll going up right now. Thank you so much for everybody that can answer it. And we'll ask Karen Weller to join us back again for the Q&A portion. Thank you so much. And then we'll go ahead and get started. I have some questions here already. So Veronica Coburnfeld, who's actually part of our team, hi Vero, thank you so much, asked, what are the indicators considered inadequate prenatal care? Anybody want to take that first? Feel free to just unmute.
I can start. This is Joanne. So I'll start with prenatal care, and when we talk about early prenatal care, is we are really looking at mothers who seek prenatal care within that first trimester. And within that first trimester, get an early indication. I think there was a comment in the chat about, even doing education on signs of pregnancy, early signs of pregnancy, and how can we get mothers, once they have identified that pregnancy, in to see a provider within that first trimester. That allows for us to have those meaningful conversations with mom, to set out a course of prenatal care with them. And then from that point on, we really recommend, in a pregnancy without any complications, at least seeing the provider once a month until about the 32-week mark. Then we start to see them about every 2 weeks, and then we see them every week. And so from the perspective of, at least when I talk about the indicators to really being able to affect the change that we've talked throughout this conversation, it's really that focus on that early, timely intervention, prenatal care to moms who have identified their pregnancy.
Are we doing it that way? Can I just hop in?
Of course, go ahead.
Okay. So I think that when I was pregnant with my Emory, I identified, I was like maybe 3 weeks pregnant, 3 to 4 weeks pregnant. So I, of course, knew that I was pregnant, and I, of course, sought health assistance immediately after. What I think is integral in terms of indicating, like figuring out if you have inadequate prenatal care, is how you feel with your provider. When I met with my provider, I was diagnosed, I was high risk. I was on bed rest for at least 7 months of my pregnancy. And during that time, I always felt that my provider was present, did not rush me through the process, did not dismiss any of my concerns, answered all of my questions. And I think one of the key indicators of having inadequate prenatal care is when you're going in, do you feel like you are present in the room? Do you feel like somebody's recognizing your being? Do you feel like they think what you're saying is important? Are they understanding your issues? Are they understanding the risks that you have? I think that that's very important to understand. So even if you you know, my mother, she told me that she didn't realize she was pregnant with me until she was 6 months. And thank God I'm here and healthy, yes. But if you're not able to identify that you're pregnant, by the time that you do seek any kind of care when you are pregnant, is that you feel like your care is adequate. Like, do you feel safe? And that's a very, very natural question to ask yourself. Do you feel safe? Do you feel safe with the life of your child in this person's hands? And also making sure that you're able to bounce some of those ideas or responses that you have to that question to other people who have had children. Is this something that's normally happening? Is this a normal practice by a doctor? So I think that outside of identifying whether or not you're having a baby or have prenatal care, is how do you feel with your experience of having prenatal care? What are some of the interactions that you have with not only the physician, but also the staff in the office, his team of nurses? What are some of those experiences and how do they make you feel? And do you feel protected and do you feel safe?
Yeah, I have my hand up because I just want to piggyback, Dr. Ashley. I agree with you 100%. I think that it's really important that birthing people are empowered and centered to and are at the center of making decisions. When I found out I was pregnant at 4 weeks, very early on, it took me a really long time to be able to find a provider. It was in the middle of the pandemic. A lot of providers weren't accepting new patients, but I was able to get in. And once I got in, I was very unhappy. It took a couple of months for me to figure out, was it me? Was I crazy? But my provider was very dismissive. Every time I asked questions, I felt like I was rushed. I kept being told, this is early in the pregnancy. You don't have to do anything. Go home and enjoy your life. And I was very stressed out about it. And it wasn't until I spoke with other women and who had encouraged me to find another provider. And I ended up switching at 24 weeks. And had a completely different experience. So I think that it's really important that women have choice and are empowered to make a choice that's best for them. And that I agree with you 100%. How do you feel with this provider? Because it's not okay to be dismissed. It's not okay to have questions, especially as a first-time mom, and feel like you're not getting answers or you're getting rushed. Or you're being, maybe you're a little crazy because it's your first time going through pregnancy, but it's really, really important that you feel trust and that open line of communication with your provider, whatever provider that is, whether it's a midwife or a physician or even a doula. So.
Thank you so much, Dr. Rokisha and Fernanda, for sharing your personal stories. I know sometimes that's not really easy to do, so we greatly appreciate for sharing with all of us. Our second question comes from Rachel Fisher. Her question is, how can doulas prioritize the birthing person as their client if they are employed by the hospital and therefore bound to hospital policy?
I guess I'll take that because I'm the one that said that. Thank you. Thank you for that. Our purpose here and what we've been working with our team on is a comprehensive plan on when there are several studies that have come out about doulas, and one of the greatest barriers to doulas is the perception of hospital providers, the nurses, the physicians, the environment, in making that doula part of the care team. And sometimes this resistance that doulas feel when they come into a hospital, that their suggestions are not taken as part of the decision making, that they are not, considered in part of the care planning, that maybe sometimes they have to really raise their voices in a way to be heard. And our goal behind this is to eliminate that and to really look at doulas as part of our care team. And we understand that this is a journey to making our hospital a place where doulas are welcomed, they are seen as part of our care team. And our goal in being able to provide them is that we have patients who are seen here at Jackson that are underinsured, uninsured, and those patients typically will not have access to being able to get a doula. they won't know how to even reach out, even after being given the information. And our goal behind that is to reduce those barriers and being able to access a very important piece of healthcare in their pregnancy. And so we're early on in this stage, we're just writing some of these proposals. We welcome, input and help from anybody who's on this. I've been reading the chat, and there's certainly a great array of resources here that can help us with that. But that's how we are looking at this and approaching it in our first phase of this journey.
Thank you so much, Joanne. Anybody else? No? Okay, we'll move on to the next question. From Ruth Jonel. I'd love to hear thoughts of if any of the panelists are open to preventative care, addressing stress and bringing holistic health services like Reiki, massages, womb wellness, herbalism, etc.
I just will jump in really quickly to say, I know that Esther McCant is somewhere in the attendees, if she's still here, but she is she is the manager of Metro Mommy Agency. And when I met her, I was so enamored by her practice because she talked about not only providing doula services, but providing a care team for her clients. So they have access to a prenatal chiropractor, different holistic methods that her and her team provide for their clients. And I don't know if we can even add her to make a few comments, or if she wants to leave something in the chat, but there are, I personally subscribe to any, holistic method, whether it's through nutrition. I definitely practice getting massages all the time. So I know that when I'm with Child Again, I will be accepting to different holistic measures to, increase my prenatal experience.
Yeah. And, just to piggyback, I think even that question brings up, the importance just about mental and emotional health and just social emotional wellness in this conversation about maternal health in general. So, there's definitely that need to ensure that women are getting the proper prenatal care, right? The proper health care, but what also contributes to their overall mental health and well-being and their social emotional wellness. So those different holistic practices that help to promote that, for sure. I'm totally on board with that. And I think also community is another big important part of that too. So what are the support systems that women have around them in terms of their partners, in terms of their families and their friends? Also contribute to that psychological and even just social emotional wellness that's critical to help ensure that women are in a good place to give birth.
Thank you so much, Jennifer and Dr. Rakisha. I did bring Esther in. Hi, Esther. Could you speak more a little bit about this?
Hi, everyone. Yes,
Hi.
absolutely. So part of the reason why I have to include that is because I do know that depending on where a client is getting their care, they may or may not get as much preventative care as possible or as they might need. And because we're dealing with a population that has so many different types of stressors, we can't ignore that stress. We can't ignore that the housing crisis that's going on right now. We can't ignore the fact that, we have to have two incomes to really live here and to thrive here. And so that means that there's limitations in where people are getting care, whether they're able to afford their insurance, able to afford, adequate food sources to make sure that they're eating healthy and things like that. So I always saw it as, this is not only the work that I can do, but if I had a team in mind, the massage therapist, the person who's, helping people work at a somatic level, the mental health therapist that I refer to, when someone I know has already dealt with birth trauma, it's foolish for me to think that I can do it on my own. And so I love that question, Ruth, because I do think that's the way that we need to start to think about things. And that's what I'm trying to enable those doulas that I do mentor, or birth professionals, or folks who want to come into this work, to understand that we can't do it alone. We have to think about it in terms of collaboration and as a team. So thank you for elevating that point as well, Dr. Rakisha.
If I may, I'd like to jump in as well. I think the holistic approach is is key. And so I thank you, Esther, for that. Thank you for the panelists for bringing that up, because stress is a high indicator of what can cause the pregnancy to not, it's not good for the baby, it's not good for the mom. We need a holistic approach, and the social emotional connection is very important. So it's not just being able to take care of the mom, but also using the community resources that are available, because sometimes especially if you have community health workers, you have the doulas, you have your midwives, if they can connect, because there's all those other areas. If you have food insecurity, if you're having problems with transportation and everything, to be able to use the community resources to help eliminate some of that stress. So you have that preventative side where, you know, you might have that emotional thing going on, but let's face it, a lot of the social activities that are going on create stress as well. So if we're able to use our connections to meet those activities, that will help the whole pregnancy experience to be so much better for the woman.
Thank you so much, Karen. Thank you so much, Esther. Really appreciate you popping in and giving us so much insightful information. I do want to touch on another question by Savannah Gray. She asked, what are some of the greatest barriers to better collaboration across policy, healthcare, and community programs / doula services to impact maternal health as a whole?
I guess I'll touch on this question from a researcher perspective. And oftentimes I collaborate with community organizations, and I'm not saying it's me, but I think that sometimes when there are well-intentioned researchers or well-intentioned institutions who want to bring about change, sometimes those connections can be inauthentic. So when I talked about what I talked about earlier was making sure that there is community-led, reproductive justice-led immersion programs for doula care, which means that the institutions already have the facility and the structure, allow the community organizations to come in and do it the way that they know that it's effective, right? And not be shepherded by the same physicians who are probably inflicting the same type of obstetric harm. So for me, I think that in looking at it from my perspective of watching these connections happen, is that there needs to be a more authentic and a more humbled approach to allowing community organizations to come in and do the work that they know is effective, and they have the data to show it. So even like with Southern Birth Justice Network, they've been collecting data about some of the births that they've had through their programs, and about the numbers of doulas that they're shepherding and mentoring that are nationwide and even in other countries. So I think it would be helpful for health institutions to be a bit more, much more flexible and open to being led by community organizations rather than the opposite.
If I may.
Of course.
I think at a bigger scale, I think there needs to be more collaboration because hospitals, I'll take the community health needs assessment. All the hospitals have to do something similar. And the health department has to do that as well. But what ends up happening is that every entity does their own, and basically we probably have the same thing that needs to be done, but because of the requirements, everybody does their own thing, and yet technically we all need to be doing the same thing together. So if we were able to collaborate and spend the dollars to really do an extensive assessment that will benefit all of the catchment areas within the community, then I think we would be so much more powerful. So when I think of the answer to that question, I think it can multi purpose, because you have the funding source. Whatever funding source you want, they want their particular data and they want you to do what they want you to do. Then you have your sometimes we'll I'll say it nicely, but we have our political thing that goes on as well. And so that plays a factor into what we're doing. And I'm afraid a lot of times, especially with the data sharing, if we were able to share data. Now, when I say share data, we have HIPAA laws and different things that we cannot, we have to be careful with. But if we are looking at the community as a whole and being able to get the information from what the clients are telling us and really work together for the community and sharing the data in that way and putting together a plan, we all have to have our plans, but if we can share, I think it was Jennifer that mentioned about I wrote it down, the template where we really look at the community and really focus on all of our strengths and going together. I think that would be so wonderful. And that is my goal, to see that really happen. But unfortunately, we do work too much in silos. And so I'm very happy that we are connecting together. And I think we have come a long ways. I've been with the health department for over 25 years. And so I have seen from when I first started to where we are now. I am so excited to see where we have come. But at the same time, I see that there is a way to go. So I'm just excited when I hear Jackson is looking at having doulas. Jackson has done a lot. A lot of community-based providers have done so much, and to be able to see that continue to work. And the only way that's going to work is if we do work collectively together. So I thank you all for bringing us together. And if we can break those silos, continue going in that path, I think that will make a big impact.
Yeah, I'd like to just add to that. And Karen, I never understood why all the hospitals do their CHNAs independently and not just like come together and do one massive one. But I think this is one of the things that we are trying to address at the foundation. We want to encourage more collaborations, and I think that in general, there's a lot of groups out there that want to collaborate, but then when you get to like the nuts and bolts, it can get very complicated because everybody has their own data systems or their own workflows or, the funding, right? Even the funding can sometimes actually cause the silos because every funder has their own requirements. So how can we bring collaboratives together, perhaps provide some funding so that they can work through like a planning of like how it's almost like dating, right? Like how are they going to like integrate and then do some more funding so that they actually can implement a project or a pilot and then see how successful that is, and then hopefully bring more additional funds to sustain the program. So I think there's a lot of like operational and technical challenges that happen that we haven't quite figured out, particularly around data. But I think that if we had the time and really came in authentically, I think we can figure some of these things out.
Yeah, I just want to agree with Fernanda and Karen said. I think that is our greatest opportunity. And when we come together, really coming together, not assuming that we know the answers, but understanding that together we are going to have so much of a stronger frame of thought, and we're going to be able to move so much faster than we're doing it independently as silos. And until we get leaders that are committed to that, I think that is one of the greatest barriers. Like sitting here today, I'm so excited to hear so many people on and just the desire to move, right? But when you think about our patients in Miami-Dade, whether they get care here, whether they get care at Baptist, it doesn't matter where they get care of, we should have one source of truth for every mom to understand SIDS. Right? Like we should have one source of truth for every mom to understand what does it mean to get good prenatal care, and coming together and realizing that it may mean that we here at Jackson, we may have to change the way we do things, or, at another hospital may have to change, or a community provider may have to change, but that change will move our patients so much further along this continuum of health than if we continue to do it in silos. And that's where I think we gain our true power behind this.
Yeah, and I think change happens at the speed of trust, right? Yes. So I think the more we can just really trust each other, have that support from leadership, have authentic communications, come at it with everybody has their strengths, right? So we don't know it all. But I think if we can start there, it will eventually, that trust can happen more and more. And then, you know, I think that's where the change can really, really happen.
Absolutely. Oh, Jennifer, go ahead.
And if I just may add this tiny little tidbit, and because I do think it's also very important, just the importance of beneficiary voice. And so I know we've talked a lot about what many of our organizations and institutions, right, what we can do, but I do feel in the process of creating policies, it's important that the individuals who are impacted by these policies across systems are brought to the table. So it's not just getting their information and then use it and then going off and developing new policies, but making sure that those individuals are able to be at the table to help make policy decisions, I think is super important. So just wanted to put that out there as well.
Thank you so much. Really, really appreciate all of the answers. I do realize that it is 10:29, so I want to make sure everybody gets out of here at 10:30. If your question wasn't answered, please make sure, panelists, if that's okay with you, you can drop your contact information in the chat, or we can share it with our with the attendees later, so that maybe you could answer some of the questions that were left. We'll move on really quickly. Kami, can you go next slide, please? Please join our Impact Agents Volunteer Corps. We are always looking to broaden our reach and have the community participate in our events. So please join our volunteer corps. Thank you so much to all of our Grand Mission donors. Without the support of our donors, we really couldn't do all of the work that we do. Thank you so, so much. A little nice gift for all of you. You can scan the code if you'd like to donate. And then thank you so much to our health and well-being pillar, Citrus Health, which we know having these different healthcare systems is really key to improving maternal health and infant health, as we've learned today. So thank you so much to Citrus for sponsoring. And please, 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 data is super important to us also. So please answer our exit survey. It's really informative and will really help us as we progress in making these impact collaboratives even better. And with that, please don't miss out. Our next Impact Collaborative is on Thursday, October 6th. We will be tackling domestic violence. What's making it more deadly? What services really work? Thank you so much for everybody for being here. Panelists, what a great joy it was to have you here. Maria, do you want to say a few words?
And well done, Viviana. Thank you all so much. We are indeed stronger together. Please join us next month as well, because there's a lot of you who are here today can also do something about that next topic. So brilliant. Thank you so much.
Oh, thank you so much, panelists.
Thank you so much. You all are amazing.
Having us.
Yes, you're all amazing. Thank you so
Thank
much. Keep
you.
doing the work. Yes. Have a great day, everybody.
Have a great day.
Thank you so much. Take
Thank
care.
you.
Take care.
Let's stay
Bye.
connected.
Yes.